Thanks so much for your words, Dr. Shin. Before I start talking about my topic, I just want to share a feeling. This morning when I saw so many familiar faces, I said, this is déjà vu, you know, the French word for something already seen. And it's because I quickly realized, because whenever I travel home in Colombia, in South America, and in the airport, you see a crowd of people. Where are my relatives? Where is my family? All of a sudden, you see some familiar faces. Say, oh, family's here. Well, I felt that. So many of your faces today, to me, are family. Thank you for coming. Recent breakthroughs in MS research and new therapies. I have 25 minutes. I will be watching that clock. So it's not easy. A lot is going on. See, I belong to the generation of doctors who actually saw the first patient in the early 1980s. It was 1980. I was in my 20s. I was doing my first residency overseas. And actually, day one, my first patient with MS, young fellow, 30 years old. And at that time, I said, multiple sclerosis? Why multiple? Why sclerosis? And that's when we go to the first slide. Okay. So the definition of MS entails actually several terms, but I just want to say a lot of things have changed in the last 3 decades. I came to this country 3 decades ago. Actually, I came to do research on ALS, but my mentors at the NIH said, Carlos, you are coming from a country where we have some trouble with some viruses. You'd rather switch topic. You are now going to work on spinal cord viral-induced inflammation. Forget about ALS. 3 decades later, significant progress in MS research and therapy, to the point I think I chose a path that was kind of more satisfactory. The other condition, it still needs a lot of research. Hopefully one day we'll get to where we are now. Definition of MS, yes, we say multiple sclerosis, disease, progressive. Dr. Chin already makes significant contribution to understand that definition. But it's just to understand, if we want to focus on research, we want to focus on those characteristics that you see there. Inflammation, demyelination, gliosis, which is basically the end of inflammation with scarring, pretty much irreversible damage. Axonal degeneration, this is not just loss of myelin. The axons, the wiring system also is impaired. And finally, neuronal loss, death of the neurons. We don't want that any longer. So focusing on those 5 characteristics is what we have to do to understand the research going on. This was the most friendly slide I could find to show. It's almost for kindergarten, perhaps, if we compare with the other slides, because the other slides I always tell the resident, this is like a picture of one of those epic battles of that saga, The Lord of the Rings. At the end, all the forces of evil fighting against the forces of, good. And, a lot of warriors, a lot of battles, a lot of destruction. So that's what you see in one of those slides. Well, this is a friendly slide. That column, that vertical column on your left, kind of orange dotted, is the last barrier, the last frontier, the blood-brain barrier. On the left of the blood-brain barrier, on the left of that column, that's the bloodstream. That's where all our lymphocytes are coming, and then they manage to cross the blood-brain barrier, and then enter. That's what you see on the right side. But you see 2 very important characters, B cells and T cells. These are lymphocytes, so kind of with a different origin, but anyway, lymphocytes. And they are necessary for us to prevent, they are very important since the moment we are born. Even before we are born, our immune system needs this type of cells, so that when we are exposed to viruses for the first time, allergens, pollen, you name it, then these cells begin to get memory and say, this is good, this is bad. The next time this agent comes, I will reject it. Unfortunately, what happens in MS, now after years of research, most investigators have concluded that B cells, but especially T cells, unfortunately get the wrong order. At the end, T cells, B cells are just soldiers who are following commands from the bloodstream. Sadly, they get the wrong order. It's what we call in military terminology, friendly fire. You are killed by your friend. But friendly fire, in biological terms, they call it molecular mimicry. So at some point, cells that present the enemy to say, go, execute, defend your country, actually are showing the picture of your own member of your army or your friend. And the cells, just innocent, follow the commands. They close the blood-brain barrier, and they go to execute. What do they execute? What is the target? Myelin, especially myelin peptides. And that's what we call demyelination. And then in this process of B-cell, T-cell activation of other cells called macrophages, so there is a big battle, a big fight. In that big fight, a lot of debris, chemical compounds come that are also harmful, contribute to demyelination, induce and contribute with axonal degeneration. This doesn't happen in one day. This takes place in years, and that's why the patient sooner or later, on top of relapsing remitting episodes, will end up having progression. And that's when we start talking from relapsing remitting to secondary progressive. Actually, they overlap a lot. So something important to understand in research. Research has focused on reducing the activity of T cells and B cells, or actually reduce the number of those cells in that compartment of the right. Keep them on the left side. Keep them in the bloodstream, sequester them, or inactivate them, or block their passage through the blood-brain barrier. If they are already in, find a way to block their activity so that the good cells, because there are good T cells and good B cells that help with regeneration and healing, they will help the so-called oligodendrocyte progenitor cells, which are cells that help myelin to regenerate. The axons will suffer temporarily, but will not die. So that's the way the brain pretty much heals in MS. So what's going on in recent research? This slide basically helps to say that when you do research, you're trying to do your best. You don't want to do harm. You want to discover something new, something productive on top of what is already known. Unfortunately, it is very difficult to find a medication or compound or procedure that is going to be 100% specific to treat the disease, and at the same time, 100% safe. Actually, as you see in that figure, specificity is kind of inversely proportional to safety or efficacy. So if we are talking down in the bottom, complete immune depletion, BMT means bone marrow transplant, we're talking that significant total efficacy, but at the risk of some eventual complications. So I'll focus my topic mainly on this issue, stem cells. And because the issue is that there are several types of stem cells. And I have the impression during, especially this year, that a good number of our loyal patients who visit our clinics probably have been misled. At some point, actually, you will notice that the goal of my talk today is to temper the enthusiasm that some of the recent publications have generated. However, I'm not going to disappoint you. But I need to clarify. There are neural stem cells. I'm not going to talk about that. That's more still at the research level. There are mesenchymal stem cells. That's when you have to be careful. Sometimes we hear that the procedure was done, that it took one day, that cells were collected from the fat tissue or were collected from the umbilical cord of a donor. These are not cells from the bone marrow. We're talking about mesenchymal stem cells. There is a significant volume of literature going on, being published already online, actually supporting the fact that there's an experimental level, mesenchymal stem cells may eventually be precursors of neural cells, including oligodendrocytes, myelin, neurons. And that's good news, but that is still at the very kind of basic research level. A lot of information is coming. In some places, they are actually inviting patients with MS to receive these types of stem cells, mesenchymal, but be careful. We are not yet in a position to say, yes, this is a good treatment, because the evidence is enough to conclude that we will recommend. So in the bottom, hematopoietic, that means from the blood. And then you say hematopoietic stem cell transplant. Actually, that's the real bone marrow transplant, stem cell transplant that in general we talk about when we talk about this as a therapy for very difficult, complicated cases. Sometimes we use the word catastrophic MS, but we want to say this is, if we say catastrophic, we mean very fast progression, severe eventual risk of progression to disability, clear evidence of inflammation by MRI. Resetting of the immune system after ablation of the bone marrow with high or intermediate chemotherapy. I'm mentioning them some of the medications, cyclophosphamide, Cytoxan, and follow with other medications to prevent infections. So on the left, and see the title, I'm talking now about autologous, means your own cells have been harvested and given to you after you are giving chemotherapy. Your own cells, autologous. This is not allogenic, which means it comes from a donor. Autologous bone marrow stem cells. We call it AHSCT in MS. So it could be myeloablative or non-myeloablative. Myeloablative means the bone marrow is significantly hit, sometimes irreversibly. And for that, you need strong chemotherapy. Non-myeloablative is kind of more mild, kind of moderate, not as aggressive as the myeloablative regime. If we go to the next slide, this is taken from a paper from one of the main investigators in Europe, Professor Zaccardi, and the slide helps to understand what happens. Basically, you have been chosen as a candidate for the bone marrow transplant, hematopoietic, and then at some point they need all your stem cells from the bone marrow. How do they do that? They actually give you a first dose of chemotherapy with special compounds, like called filgrastim, that actually helps the stem cells to detach from the bone marrow, come to the bloodstream, circulate, and then you collect them. You collect them, and then with a special technology, you may actually choose those which are stem cells and discard the others. Then you freeze them until you are going to use them. A few weeks later, then you get the real chemotherapy that pretty much shut down the bone marrow down to zero, to a level that any virus, any fungal agent, any bug can cause significant, maybe fatal disease. That's why patients go to bone marrow and remain in the bone marrow 2, 3, 4 weeks, actually being prevented from any exposure to infectious agents. If you are a visitor, you have to dress like an astronaut with total protection. So this is what happens. You are giving back your own cells that you donated, your own, we call them CD34, that's the marker. And then those cells are there to repopulate the immune system, the bone marrow, resetting the immune system, especially the T cell compartment. And that's when you hear, well, this patient went for bone marrow transplant, he has had no more relapses for 5 years. And that's when you begin to hear, is this the cure? So, AHSCT in MS. It has been given to about 900 patients reported in the medical literature since 1995. This was started by a Greek doctor, Professor Fassas, in Europe in 1995. He was the first person who conceived this, a hematologist, and since then, about 900 patients have been reported in the medical literature. Most of you know that in the United States, especially the team that has reputation for doing this is the team at Northwestern University, especially led by Dr. Richard Burt. There is another team, very important. This is a combined Seattle, Washington State, Denver, Colorado team, led by Dr. Nash. And medical reports are coming from them. We're going to discuss those reports. So what is important, the second paragraph, and especially you see the red paragraph, we say a useful therapeutic alternative, I'm talking about the transplant, in young patients with catastrophic course of disease, as long as the transplant is given during the first 5 years after diagnosis. They have also come with some statistics. They say, hopefully the patient should be younger than 40, hopefully less than 5 years of disease, hopefully with very aggressive disease by MRI. They say that is the perfect patient for a bone marrow transplant for MS. So what we did, especially this year, we decided to review the last 5 publications on bone marrow transplant. 4 papers came last year, 1 paper came this year. And some of you have actually shown special interest in that 5th paper, with all respect, coming from Canada, from the Ottawa team, Dr. Atkins and Dr. Friedman. And this is important because the message that team, with all due respect, sent is that that is the cure. And again, I'm here to temper a little bit that enthusiasm, but with a positive outcome. So this is what happens. That's the table. On the top, you see the last name of the investigators. So let's begin. The first one, Mancardi. That is the Italian European team. That was the first paper published February last year, about 21 individuals. And this was a comparative study, transplant with Novantron or Mitoxantron that Dr. Chin mentioned. The second team, Nash, that's the team from Denver, Seattle. The third team, Richard Burt, that is the Chicago study. See how many patients they have recruited, about 151 or more. The fourth team, Shevchenko, of course, Russian. They have a very important bone marrow center in Moscow. The last team, Atkins. So this is Atkins and Friedman. Keep an eye on the number of individuals recruited, 24, and only 21 finished the study. And this is very important because the outcome is not a friendly statistic. That's why I'm here to temper that enthusiasm about that protocol being the cure. We will discuss why. Next slide, on the second row, basically is the different modes of mobilization of the cells that they use, cyclophosphamide, filgrastim. Something important is that the team from Canada did something very positive. They actually were able to label the stem cells before the transplant, something that the other teams had not done before. So if we go quickly to outcome, this is what happened, that one patient died in the Canadian team study, and another patient almost died. The main reason related to this is because the Canadian protocol, opposite to the other protocols from the other 4 teams from last year, the Canadian protocol actually included busulfan, which is a very strong kind of toxic chemotherapy agent. However, busulfan has the ability to do something that the other medications cannot do. It can mobilize the aggressive cells that live, cells of the immune system that we call microglia, which live in the brain. Busulfan gets there, gets them out, and facilitates new microglia to come. This has been found in animal models of bone marrow transplant. So the issue is, could this be a cure? Eventually. However, 2 patients died one died and another almost died. That means 2 casualties among 24, means 8% of complications. We cannot afford that. And those of you, few patients here, who have discussed this with me, especially the attention to the Canadian study, have noticed how I react to this, more friendly than I'm here today. So be careful with what is coming out from the medical literature. We feel that the teams from from Chicago, Denver, Seattle, are doing a good job. They are being very careful choosing their patients, especially day 1 patients who especially have some kind of, still some evidence of inflammation, relapsing, remitting, or MRI evidence of activity of disease. This is basically a slide quite similar to Dr. Shin's slide showing the different stages of MS. But again, we don't feel strongly, how can I say, compelled or motivated to refer patients to bone marrow transplant if they're already in a clear stage of secondary progressive MS, because ultimately we don't want to stimulate the patient to hope for something that probably will not meet their expectations. At the same time, a lot of new therapies are coming. Still, the bone marrow stem cell transplant, we believe is still a good therapy for the individual with extremely very fast progression who is not responding to available medications in a reasonable period of time, a kind of last resource. This allows me to jump to this slide. It's about what's going on with other therapies. So we said that the important lymphocytes that cross the blood-brain barrier and begin the attack, B cells and T cells. So initially, during the first years, basically, we focus on therapy for T cells. That's why cyclophosphamide, Cytoxan was given as last scenario when, let's say, when Lemtrada was not available, rituximab was not available, and even in the early years of Tisabri. Nowadays, research is showing very important, very positive outcome that if we deplete the B cells, actually the patients will have a significant reduction of inflammation and progression of disease. There you see the different stages of B cells from bone marrow to the moment they are released into the bloodstream until finally they get to the plasma stage of so-called plasma cell. So they have a different stages in life, and during those different stages, they are kind of showing a receptor, a special protein in the membrane that if we block that with a monoclonal antibody, actually those cells are out. So that's what the new medications are showing, especially B-cell depleters known as rituximab, and a modified form of rituximab, more friendly, called ocrelizumab, that has shown very good results recently. So I invite you basically to focus on the title, relapsing remitting. rituximab, and then that graph on the right side that shows that the number of enhancing lesions dramatically decreased in the patients who received the rituximab opposite to those who received the placebo. Again, relapsing remitting, this time the other medication, ocrelizumab, also showing significant good outcome in comparison to individuals who were treated with other medication, in this case beta interferon, and showing also good outcome. Then we have relapsing remitting, two more recent clinical trials that they call OPERA-1, OPERA-2, that are also showing that the individuals may show a reduction in progression towards disability. The same, rituximab in primary progressive. So there are two studies showing that rituximab works in primary progressive, I mean the so-called Olympus study, and the other study, primary progressive MS and so-called ocrelizumab. So again, these two monoclonal antibodies that significantly deplete the B-cell population actually have been shown to be useful for patients with primary progressive. Interestingly, the question comes, so what about secondary progressive? We already have information that these B-cell depleters work for relapsing remitting, work for primary progressive. Remember, in the clinical setting, we see that many patients having relapsing remitting MS also are showing progression towards secondary progressive. We see patients with secondary progressive MS who also have relapses. We feel that soon we will have studies where finally they can tell us that ocrelizumab hopefully can help. The main reason we are enthusiastic about this is because at the research level, it has been found that the cells of the immune system organize themselves. They regroup in the meninges, actually kind of defending against the normal immune system. And if these medications get there, actually destroy them, therefore leading to eventual healing. The next slide is actually a commercial, because this is not new research. I say a commercial means no matter what medication the investigator, the researchers, the clinical trial is considering, always keep in mind that you need to take your vitamin D. When we were medical students, we were told vitamin D's role was to keep calcium in the bones. Nowadays, we are all pretty much obsessed and compulsive, pushing hard for patients to take vitamin D, because all the important relations vitamin D has with the immune system, as you see there, is basically an enhancer of the good Th2 and other cells of the immune system. And then this, many of you who are following this literature very actively have read about the anti-LINGO. Well, LINGO is actually an abbreviation. And basically, it deals with a so-called, in biochemistry, we say a transmembrane protein, that basically its role is to keep dormant the cells that are going to promote the formation of myelin, keep them dormant, silent, inactive, the so-called oligodendrocyte cell precursors. So if we block that transmembrane protein, if we block LINGO, so I call it the anti-LINGO with the monoclonal antibody, then perhaps there will be remyelination. So there have been already some pilot studies, at least showing that, for example, one of the parameters for the function of the visual system, that the vision may work better. I understand they are now recruiting, or there is a study going on with patients with this medication, anti-LINGO, either with multiple sclerosis or optic neuritis. So this is important to keep in mind, that at some point this will reach to a state of finally phase 3 trials, eventual approval by the FDA. So let's keep an eye. This is one of the very promising therapies coming, anti-LINGO. And this, why do I bring this slide? It's because I know well the doctor behind this, Roland Martin, was at NIH for several years during my years there, about a decade ago. And then Roland returned to Europe. And he has been involved in a very interesting study and protocol, which actually entails collecting your cells. You go early in the morning, you sit there. Let's pretend that it's like a dialysis or like a blood transfusion unit. You are given a very comfortable recliner chair. You give your arm, and they actually get one catheter in one arm, another catheter in another, and your cells, your blood, your complete blood goes through a machine. The machine actually separates all your lymphocytes. We call it lymphocytopheresis or leukapheresis. And actually, this is the machine. And then the investigators, after like 3 hours, 2-3 hours, collect in the back all those lymphocytes, take them quickly to the laboratory, and then wash them out and expose them to the myelin peptides to which, if you have MS, those cells are actually reactive to. In other words, before waiting for the attack one day in the future to the real myelin, those cells are given an early exposure, so they are kind of surprised, and they say, okay, now I got it, so I will rather retire. And they are beginning to see some interesting outcome. This was just a pilot study with about no more than 13 patients. The last time I saw Roland during a meeting here a few months ago, he didn't make too much noise. I have the feeling that this procedure is going to keep us talking, especially actively, in the future. Finally, what do I tell to many patients nowadays? I say this: if a new patient comes today who had optic neuritis first episode 3 weeks ago, or any other symptom, MRI is talking by itself, well, yes, you have MS. What do I tell to that patient nowadays? I tell them, in about 10 years, if a new patient comes, we're going to do a combo therapy. It will be a combination of procedures, monoclonal antibodies, immunomodulators. And after 3 or 4 months, we will be able to face that patient and verbalize that magic word that is still forbidden in our jargon. We will be able to say, Madame, your MS is in remission. And with that, I finish my talk. Thank you.